that's beautiful. Look at that background. Social distancing. Frederick's on to help us if we need any help, isn't he?
What's that?
Frederick's there. Freddie?
Yeah, Freddie. So we'll be ready to get started in a couple of minutes. What I need assistance with, Gavin, is I have to share my screen. I'm still in up in Dropbox. I'm not easily. Maybe if I get out of Dropbox.
Hey, Becky, do you know if there's an EADS sign-in for this talk?
Because
it wasn't.
Freddie is on the line, I believe. And
yes, there is.
I didn't see it in the meeting invite.
18 ALIT. 18 ALIT. This is Nash.
Thank you.
Sure.
18 AIT.
ALIT.
18 ANIT.
ALIT. L is in Linda.
That's correct.
I added it to the chat window so you can reference it there as well.
Thank you.
Gavin, when I do this, I'm back in Dropbox. Guess we'll run it in Dropbox. I don't see how to do that. If I,
What you need to do is you need to get your presentation up on your screen, and then in the bottom of the Zoom thing in the center, it says share screen. When you hit that, it will show your slides up in the main box.
good morning, everybody. Freddie, can you please tell people how to get credit for being on this Zoom conference?
I'm sorry, what'd you say?
Can you please give people instructions?
Oh, sure. So everyone should mute their mics. If you don't know how to do that, I can do that for you. And if you have questions, you can type them in the chat box. For the time being, at least.
Gavin, if I give my control to the screen to you, can you get off of the Dropbox?
Becky, I think you need to get a little bit closer to your mic. You're sort of coming in and out.
How about now?
Better, but you could be closer.
You sound like you're underwater.
Morning, Becky. How are you today?
Good morning. How about now?
Much better.
Yeah, very good.
Okay. We're working with some technical difficulties here. Just a minute.
So Becky, if you go to share screen, you can load up PowerPoint to share screen.
We can see your screen.
Okay. And it says this page can't be displayed. Is that what it says right now?
Yeah.
Okay. And I need to, Gavin, go to Dropbox, which is where you.
Yeah, you get that there, Becky?
Yep, I'm making one final adjustment, so I'm looking at the right keyboard and moving this over. Okay, let's get started. The topic of this talk is the COVID-19 pandemic and using respiratory protection science to treat your patients and protect yourself. Can everybody hear me? Gavin, can you hear me, I guess? So
Yeah.
Yes,
we can hear you.
Terrific. I'm delighted to be sharing the podium with Dr. Gavin Macgregor-Skinner, who's a colleague in public health sciences and has amazing boots on the ground experience, as you will see. The way this session will be organized, Gavin, there we go. We have 6 objectives, starting with the science of infection airborne transmission, very important in order to understand what we're dealing with as healthcare workers, looking at transmission pathways, and then getting very practical. What are the respirators? How are they being performed? Can you optimize use? The author, Atul Gawande, who's also a Massachusetts surgeon, had a New Yorker article just a few weeks ago talking about the importance of the healthcare worker caring for the sick, and then posing the question, how do we keep healthcare workers seeing patients?
The gray rooms.
Patients.
So,
as you can see,
so I'm gonna
please, if people can please mute, I'll just talk over you. So the answer is to have a COVID provider safety program. This hierarchy of control strategy is a cartoon you're going to be seeing repeatedly through the talk and speaks to the importance of a hierarchy of control strategies. In this COVID pandemic, all hands need to be on deck in trying to protect healthcare workers, because we can't remove the hazard, we have to take care of patients. We cannot isolate ourselves from them, although we can do tremendous number of things with engineering controls. And then eventually, one piece that we're focusing on today is the personal protective equipment. Next slide. Okay, next slide. The next few slides are going to show key advances in aerosol science that give us very important lessons as we're thinking about being in an environment where there are infectious aerosols. Let me give you a piece of terminology first. An aerosol is the suspension of liquids or solids in a gas or air. You'll see lots of terminology, droplets, particles, that sort of thing. For this talk, we're going to talk about aerosols, the suspensions of liquids broadly, and if there needs to be a specific subset, you'll see that coming up. So 4 examples that we're going to walk through quickly. Dr. Riley in 1959 was taking care of wards of people with tuberculosis thought to be spread by contact. He thought maybe that it was in the air. And so he put guinea pigs in the ductwork of a tuberculosis ward. Anyway, that's what he did. And the guinea pigs all developed tuberculosis, even though they were never handled, so there was no contact. And this was very important in our understanding that tuberculosis transmission can be airborne, and this idea of droplet nuclei, and really was the beginning of the current bioaerosol science. Next slide. So what did we do as a result of that? Well, all the things that we're familiar with doing on the hospital wards, quarantining suspected TB cases, negative pressure rooms, wearing a respirator and going into an anteroom before entering the room, all this started with Dr. Riley's key observation that guinea pigs up in the ductwork can contract tuberculosis without ever touching a patient. Next. So 1977, fast forward. What about Homer, Alaska? And how did you all have been stuck on the runway with an engine, with an airplane that didn't work? Okay, this is what we learned from that. We learned that brief exposures can give a high risk of illness in an enclosed space, and that there's a dose response. So next slide. Here's what happened in Homer, Alaska. An airline was stuck on the ground for 3 hours because of engine failure, And in retrospect, the ventilation system was inoperative, and there was one sick patient. There were 54 patients on the airplane, and a primary care physician who was in Kodiak, Alaska, happened to suddenly see 7 people who were acutely ill, and 2 of them required hospitalization. And then 2 crew members got sick, and an investigation started. And it turned out that this was an influenza virus. Next slide. What's important here is the one sick person on the slide, on the flight. And here 2-3 days later are all these people who became ill. And just because the isolated nature of Kodiak, Alaska, and an alert physician, this was recognized as an index case. But here's the thing that's important for us today. They looked at how long people stayed on the airline. Some people got off, some people stayed. And the attack rate, the percent of people who were infected, went up tremendously depending on how long they were exposed. Next slide. So the takeaway message from Homer, Alaska and the airplane is that brief exposures in enclosed, non-ventilated spaces without protective gear can foster transmission, and that exposure time matters. And that also you can define the incubation time for influenza from this kind of example. Next. Okay, fast forward now to SARS in 2003. Here's where we started to see healthcare worker risk being identified, with a sizable proportion of early SARS cases and critically ill healthcare workers. And the idea of the AGPs, the procedure-specific risk, started to come out both in an individual case reports and then a more recent meta-analysis that identified several specific tasks as being associated with increased risk. And as we talk later about aerosol generation and transmission, this will make sense. And you'll see why there's a more expanded list of also aerosol generating procedures. Next. The other thing that the SARS outbreak gave us is this notion that there can be spread within an immediate neighborhood. And Dr. Macgregor-Skinner, I learned last evening, actually has been to the Amoy Gardens housing complex in Hong Kong. And here's what it looks like. Over here on the left side is that yellow building, that's a single building, and a single individual went and visited this building and was ill and had diarrhea, flushed the toilet, and was there for a while and then left. And here are these other buildings, B, C, and D. And you can see here that E in this building, here are 321 people who became ill from a single ill visitor with SARS. And this building, which is where the individual was, had at the peak 35 cases in one day, whereas this place, which was not proximate to it, had only perhaps 4 cases. So you can see that that where you are relative to where the point source is, the person who is ill, and then how the ventilation and plumes are, can make a big difference. So location matters. And the other thing that was important in this outbreak is that management and security staff who were touching and interacting with people were not affected. So that airborne spread, again, became important. And on the upper right-hand corner are these plumes. The blue lines are the plumes that were modeled as coming from that staff. Now, just yesterday, this is close to home. My husband's a choral conductor, and I sing in choirs. And the Valley Chorale up in near Seattle, an hour away from Seattle, had a choir rehearsal where the choir director decided not to go ahead and hold the rehearsal. Nobody in the area seemed to be sick, and people were careful. They used hand sanitizer. They brought their own music. They avoided hugs. There was a 2.5-hour rehearsal, and they kept a distance. 3 weeks later, 3/4 of them are ill with COVID-19 or with either diagnosed or with symptoms, 3 hospitalized and 2 are dead. And they thought back on this fateful evening, and they thought, no, there was nobody that seemed to be coughing or appeared ill. The importance of this one is that it really has us paying attention to the idea of asymptomatic spread, and and that we can't only rely on coughing and sneezing when we as healthcare workers are thinking about the community where we're working. Next. So the main points of this first section of the talk are that there's high transmissibility, transmission before symptoms, risk of group meetings, risk of enclosed spaces. And so that asymptomatic transmission becomes important. And then the question of how do you know if someone is contagious? And the message is you protect yourself when you're in a healthcare setting. And we'll talk about that later in this talk. Next. So here is a sketch that is talking about how you think about that. Here is this in the most purple, and is someone who is generating the viral particles. And the largest particles will drop to the ground within a short distance of the person. These land on the floor and on materials, and that's why cleaning, that's why the environmental staff who clean the floors are heroes for us all. They help remove these burdens. Then there are also some of the particles don't just drop to the floor, but they stay in the air. And they can travel this distance, 3 feet, but they can also travel and become droplet nuclei in the air. And this is why ventilation systems and respiratory protection become important, because when you're in that space, even though you aren't right up against the patient or the source, then you can still have potential exposure. Next. So that, how do you protect yourself given this information? Well, protecting yourself is repeated situation-specific risk assessment and management. It just is something that that I expect for many of you has become a new habit. One of the pulmonary critical care fellows, who's very much on the front lines, said, you know, I always kind of popped on the respirator, but I never really thought about it. I think with contact exposure and the degree of this pandemic, people are much more interested. So in order to understand transmission, you need to understand viral load, and to estimate that, you need to think about the transmission pathways and the routes of entry to your body, eyes, nose, and mouth. And so here in this cartoon, the patient is the person with the high infectious load. If you are intubating, helping with the ventilator right up at the patient's face, here you are. If you are further elsewhere in the room, there might be a lower infectious dose. But you think about when you're entering a clinical situation, you do the mental pause. You go, okay, what's the situation? Let me just think in terms of this exposure transmission pathway. Then think, am I personally as a healthcare worker protected for this situation? And if yes, act. And if no, finish the protect yourself, the suit and seal, and then act. And Gavin will talk more about this. Okay, so let's talk more about this transmission pathways. Next slide. Here are transmission pathways. Here you have on the left in brown, you have an individual who has the COVID virus. And they may be coughing, sneezing, talking, breathing, singing, spitting, many different ways that viral particles can get launched into the atmosphere. I've seen people, when they're doing the nasal swabs, we had a webinar with China, and they were showing how the healthcare workers would stand at the side when they did the swab. And so if a person were coughing, that aerosol would be launched forward where they would be off to the side. So thinking about where the aerosol is. The other thing about the COVID that they're starting to see is early in the case, there may be more nasopharyngeal, where the virus is centered. And then if someone develops the acute respiratory distress and the hypoxemia, then viruses are more likely to be identified deep in the lung. And again, I showed a minute ago how the droplets can land and they can also be dispersed. And so once again, mental pause. Okay, what's the situation? Am I protected appropriately? If yes, act. And now this, as it becomes a habit, this can happen. This you will do fast and quickly, just like Steph Curry can launch a basketball so quickly and so perfectly. and yet he practices. So this is the practice. Now, let's talk about the respirators, because if you are trying to protect yourself, you need to know your respirators. So the way respirators work is they begin with the OSHA standard, Occupational Safety and Health Administration, which is the Department of Labor. And the law says that that every workplace needs to have a respiratory protection program, and that's to protect exposure to contaminated air and to prevent occupational illness. And remember, this cartoon here shows that personal protective equipment is at the bottom of the control strategy, meaning that all these other things, engineering controls, administrative controls, the things that the COVID units that our engineering folks have set up for us, all of these things are very important as part of the hierarchy control. And it's also very important to have a personal protective equipment. Next. So here they are. And here, these are cartoons, and you can find this document online if you want to look at 100 pages of detail. But bottom line, these are air purifying respirators. So the purpose, and a respirator is a specific form of a device that fits over the face, and with the purpose of removing contaminants from the air. If you go to Home Depot, there are many different kinds of filters. Some are for vapors, but what we want are the ones that are going to remove the particles. And so that's number one, this half mask, the one that goes over your nose and mouth, absolutely needs to be fit tested. And Gavin will tell you how to fit test yourself, which you need to do every time you put on the ventilator, the respirator. You don't do the formal fit testing, but you need to know how to check your seal. The next big, there are these other elastomeric respirators, and then here are these positive air purifying respirators that can have a number of different interfaces, and some of them have tubing here with the pump and the filter down here. Some of them, there is not a tubing and there's a filter up here. Next. So the question is that you may be wondering, you say, do I have a NIOSH approved N95 respirator? And here's how you know. Right here on every respirator is a description. It'll say what kind of respirator is it. It'll have a number, and you can then look up on the CDC website to NIOSH, and you can both verify that you have a NIOSH approved respirator, and you can also tag into information on how to use it. There's been wonderful information and training that's out here at the medical center that I encourage you to access and to watch. And there's also this central list that the government maintains. And you can see that it says right on the mask that this is a healthcare particulate respirator. Okay, next. So there are trade-offs. Those of you who have used respirators will recognize these, that as you're breathing, the breathing can feel a little bit different. The thermal temperature issues, for some people with glasses, there may be fogging up. Some people may find it easy or more difficult to communicate. And then if you have to eat or sneeze, what do? You have to be mindful and know that you have a respirator on. And so you have to think through, you can't, you have to be mindful of that. Next. I understand in talking that a lot of our surgical colleagues have recognized this, and there's a profusion of shaved faces going around the medical center, and I think that's terrific because for having a good fitting respirator, you need to have a good seal, and that doesn't happen if you have facial hair, and so clean shaven, and then some very limited bits of hair are appropriate, but Verity, Garibaldi, and the French fork and others just are not something that, not a way to wear your facial hair during this time. This is a figure that I found that explains this business of how a mask is hot. So our skin temperature of 34 degrees feels normal to us, and most people, if you go up a degree, it starts to feel a little off. Surgical masks can increase, and respirators can take you up 5 degrees or even 7 degrees. And here you can see there's quite a bit of variation. So here's lip temperature, and then you can see if when a person is working that there may be this 5 or 7 degree increase in lip temperature, but there's also a tremendous amount of variation. So some people may find that it's not a big deal to be wearing a respirator and it somehow doesn't increase the temperature, whereas other people do. Next. Another important issue is that masks and that your breath generates moisture. And so saliva and droplets and sweat all can contribute to the moisture of a mask. And the N95 committee that is working very hard right now is paying attention to this issue of respirator moisture and how to train people and so that their masks, so their respirators dry out. Next. Okay. And then finally, there's this, I'm going to call this broad category respirator hacks. This was suggested by someone much younger than me who said hacking is the way that you try to adjust and come up with fixes or things that are not straight down the middle. So let's just walk through some of these things. Next. Okay, here are procedure masks or surgical masks. These have as their value keeping you, if you are infected, from exposing others. Or if you're doing a surgery, a surgical mask keeps you from having droplets from your mouth landing in the surgical field. So in the left here, you have an infected individual who has a mask, and you can see how their viral particles are landing on the inside of the mask, and the leakage that does occur because these masks are not sealed, they get entrained in the plume and then they go up like this. And so that a nearby individual without a mask will not be exposed. So an example of how this is used in the healthcare and infection transmission setting is that institutions have proof of vaccine stickers for the influenza vaccine. And so a healthcare worker who declines the influenza vaccine will be mandated to wear a surgical mask when within 6 feet of others. And in some institutions, according to their policies, it's recommended. Some institutions mandate that. But the idea here is that a healthcare worker can be a vector, can transmit influenza vaccine, and has the ability to protect themselves by having, the healthcare worker can have the influenza virus and has the ability to protect themselves through a vaccine. And so therefore, if they do not protect themselves that way and do not protect others that way, they protect them by wearing this procedure mask. Now, the next thing is this outpouring of masks, of sewing your masks. Here's the costume director for the Minnesota Opera, who is benched because the opera is shut down for the moment. And so she's busy sewing masks out of tremendous concern for healthcare workers and also to try to do their part to attack this virus and bring this under control. So what do we know about that? Well, I found this on the, and this is looking at various household materials. If you're going to grab something and turn it into a mask, how good is it? Well, it turns out silk is the least good. It only gets 50% of a protection. Other things like a pillowcase, up to 60%, a cotton t-shirt, 69%, a dish towel, 83%, vacuum cleaner bags, the HEPA filters, their fabric is 95% effective, and here's the surgical mask at 97%. But here's the thing, these do not seal. So leakage is incredibly important. And so if you've got this great fabric right in front of you and you take a breath in and the air comes in from the sides, and then all of a sudden you're having an exposure to the virus you're trying to avoid. So these improvised protective masks are non-sealing masks, and they do not take the place of an effective respirator for a healthcare worker. Can they be used to limit exposure into the general public? Can people wear them out in the community? I think that's where they may have a role. Now there's a variety of combos that people are trying, much less information about that. I think Gavin will talk about a surgical mask placed over the N95 or a shield over the N95 to get rid of the spatter and to try to increase the life of the rest of the N95. Next. I found an example of a PAPR, positive air purifying respirator, and an N95 on top of that used in a very specific situation. Item next. Okay, a question, there are a lot of questions that people have sent our way, and I think we'll continue to collect them and try to see if we need to have a forum for disseminating the information. Somebody mentioned having a respirator that someone brought from out of town, that their husband brought from out of town. And the question was, can they wear it to work? And I asked Gavin about this because he's worked in many practical situations, and his instant response was yes, if it passes a user seal check. So I think this is one of many questions that can come up about how to address possible shortages. Next. So newer ideas. There's the Innovation Center that's very interested in contributing and having newer technologies. And here are some of the things that are floating around out in the literature. One is some kind of an air jet directed at the point at someone who's infected. There's some problems with that, but that's something people are wondering about. There's an air supply pillow. There's a combination personal ventilation and vertical ventilation. So if you can somehow suck the droplet nuclei coming out of an infected person, get them out of the way, then maybe they won't go out into the air. Obviously, in an intensive care unit, there's some practical things, but that's what people are wondering about. And I think those of you who are frontline who are thinking, gosh, there's something that would be a great idea. I think sending in ideas to the Innovation Center is a way to move ahead in this area. And NIOSH has said that in the setting of resource limitation, they've talked about using a ventilated headboard, another modification of this point source ventilation, sucking exhaled air from the patient. Next. So in summary, here's the overview of respirators and face masks. The top two lines, which are do-it-yourself masks and surgical or procedure masks, do not have a seal, a face seal, and so as a filtration system, they are not effective. The filtering face respirators with the N95, which is our workhorse for filtration, is for this, the seal is essential, and fit testing is required, both to know that you have a respirator that fits your particular facial contours, but also as something that you do as part of your risk assessment every time you put the respirator on. And then finally, the positive air purifying respirators that have a variety of protection factors depending on their hood. And Gavin will talk about that. So now I'm going to turn the podium over to Gavin, Dr. Macgregor-Skinner, a Penn State colleague, an amazing resource that we have here at our institution. He has boots on the ground experience at many places around the world. And I'm going to, my final slide is to show you one example in a broad brush of how in very difficult situations, healthcare workers have been able to be trained and to protect themselves. This is the Ebola virus outbreak in West Africa. And the green line is the thing I want you to particularly look at. So you can see early in the outbreak, people didn't know what they were doing. They didn't have experience, and 13 to 16% of healthcare workers were being affected with a very high case fatality rate, much higher than we have here in COVID. But you can also see that with a few bumps along the way, over time, people became very adept at protecting themselves, so that training on infection control for every healthcare worker in this high-risk situation in resource limitation in West Africa allowed the healthcare worker burden to go way down. And so I think this is our challenge, and to take on the COVID epidemic to work on this, take care of people, but also to learn how to protect ourselves. And then, Gavin, let's have you give us all that practical information.
Thanks, Becky. Good morning, everyone. So I'm going to talk about some recommendations. These are my personal recommendations. It's not law, it's not legislation. I'm talking about some of my operational field experiences of how to protect your eyes, nose, and mouth. Again, I want to emphasize, and Becky has mentioned this, you need to do your own risk assessments, and we do risk assessments every day because we're dealing with a viral pathogen that has no cure and no vaccine, and we provide supportive care to the patients that we treat. So in every situation you find yourself in throughout your shift that you work in the hospital, you need to be continuously doing risk assessments. I just want to start with many of the states, counties now have told residents to stay at home. This is the map taken last night where states and cities have told residents to stay at home. And this just happened to me in Washington, D.C., where I live, last night. So I was in a hospital yesterday working. I got this text message, stay at home, starts at 8 p.m. No Marylander should leave home unless for essential reasons. It's the same in Virginia, or the same in D.C. And I didn't pay a lot of attention to that until on the way home, I was stopped by a policeman who said, "Where have you been? What are you doing?" And I actually had my Beth Israel Deaconess Medical Center ID card, which on the front has my name, tells everyone that I work in the Department of Emergency Medicine at Beth Israel in Boston. And on the back, it has that I'm an essential employee. And it says during a disaster, I'm an essential employee and I can pass through checkpoints. When I rang back the hospital I'd been working yesterday at, and I said, I've just been stopped, and I used my Beth Israel Boston ID to get through and show the police that I was an essential employee. How many other hospital staff have that on the back of their ID card? And what do we need to do today? And what we found out, a lot of the staff that are essential to the function of our hospitals in Maryland, Virginia, DC, and other areas don't have that essential employee. So we'll be reprinting ID cards today to ensure they do have that. The other thing you can do, if you do have it, and I would highly recommend now that those stay-at-home orders are in place, is to carry a business card. At least that gives you some credibility of what you do. So today I'm going to talk about how to prevent shortages, exhaust our supply of face masks, respirators, and eye protection, but to ensure that all of our staff, everyone, has access to necessary equipment to do their job safely. And everything from triage to patient care to environmental health services, cleaning and disinfection. And the way that I need that everyone in the team, and this is a team-based approach in every hospital I work in, is you have to understand you need to cover your holes. The holes are your eyes, your nose, and your mouth. And we have to protect the face. And if people understand that, then they'll understand why we're putting so much emphasis on the engineering controls, the administrative controls, but more importantly on the personal protective equipment, because if we don't cover our holes, we open ourselves up to higher risk of getting infected. This discussion we're having right now about reusability of face masks is not a new one. So in my career, when I worked at CDC during the SARS outbreak, 2002, 2003, the reusing of N95 respirators has been a constant source of conversation and discussion. The Institute of Medicine, this is freely available on the internet, published in 2006, their guidelines on reusability of face masks during the influenza pandemic. And again, in 2014, I had 3 trips to West Africa, setting up, establishing, managing Ebola hospitals. I also worked at Emory University Hospital, focusing on provider safety for their Ebola patients. On my second trip to West Africa, I was asked to manage and supervise a hospital where 24 of the doctors and nurses had just died. And it wasn't just the personal protective equipment that we had a shortage of, it was the lack of utilizing the engineering and administrative controls. And in that, what we're finding now, the discussion we're having here at the US is about, oh, the N95. Well, it's much, much more than just the N95. It's all those hierarchical controls that Becky outlined in her presentation. The other discussion we're having right now is that, oh, companies are going to start making ventilators. Well, how many people do we have trained in our hospitals to actually operate and learn and be educated how to operate any new type of equipment that comes in, and that's going to be very challenging for us. How many people do we have now that can operate a ventilator? We're seeing people out of the goodness of their hearts make procedural masks, sew them in their homes, and distribute them. Again, I've got to emphasize back, every time we have to cover our eyes, nose, and mouth, you've got to do your own risk assessment and acknowledge that there is risk based on this coronavirus or any other infectious disease that's out there, and don't just accept what people are giving or telling us to do. We've got to base everything we do on risk. I'm going to talk about sort of some of the personal protection equipment, and right now, most of the frontline health workers, first responders that I work with and I train and educate will be wearing an N95. We don't wear it below that when we're having direct patient contact or contact with the community. Protecting your eyes with glasses, eye goggles, and face protection with a face shield. And again, a lot of these face shields are being made in the community. We have a big volunteer group here now that's actually making out of plastic and Velcro and material, making face shields for a lot of the hospitals. And I would always wear at least these 3 whenever I'm going into the hospital at a minimum, based on my personal risk assessment. But what I am wearing every day right now is a powered air purifying respirator, a PAPA. Again, of all the hospitals, I was in Boston, Martha's Vineyard last week, hospitals down here in DC, Maryland, Virginia right now, helping them with their provider safety programs. Every time I go into a hospital right now, I'm wearing my PAPA. This particular one, it works on positive pressure. It has a 10-hour battery life. When I come out, I clean and disinfect. A lot of hospitals do have other types of PAPAs. One of the things that all the physicians and the nurses that I work with at the moment, we're teaching them and educating them how to clean and disinfect their own PAPA. This is my PAPA. I don't share my equipment with anyone else. The same with my face shield, my N95, and my eye protection. It doesn't get shared. It is my own personal protection equipment that I keep for myself. And if we have to extend or reuse that, we don't share it with others. So again, this is just a photo here of, again, well, when we're not actually working in the hospital, we're actually training. So I'll be training, practicing donning and doffing all the time. I want to emphasize it's not just the personal protective equipment. Again, with the hierarchical controls we have, administrative engineering controls are more important and provide better protection for us in a hospital patient care setting. This is a photo from a training that I did recently in Tennessee, where the hospitals brought in their personal protective equipment that they had right now. We had 34 different combinations of PPE in this workshop. And again, I was able to make 33 of the 34 combinations work for direct patient care and treatment for coronavirus and other high infectious diseases. But again, once we work out what the hospitals have got, we then have to then write their own standard operating procedures, and then we rehearse. And a lot of what we do is made by video. So in this particular workshop, as we were donning and doffing and then wearing it for an extended period of time, if you haven't worn an N95 for an extended period of time, now is the time to do it, not when you're told to go in and provide care to a patient. For me personally, I can wear an N95 for 2 hours and then I'm completely out of breath and I'm exhausted. And then after that, if I have to wear it a second time, I may only be able to wear it for about 45 minutes. So you need to start practicing and getting used to the equipment. Again, we've talked about these infection prevention controls, how to minimize exposure. We do risk assessments. We look at administrative controls, engineering controls. A lot of hospitals I've gone to now are modifying rooms by taking windows out, putting in extraction fans, creating negative air pressure, or just creating a unidirectional flow of air to create high turnover of air. When we look at our standard operating procedures, we don't just keep those. These are evolving and we change them all the time based on the situation, based on the people, based on the person we're working with. Everyone's different. We look at entry and exit processes as well as our emergency procedures. If a patient crashes, and I saw this the other day in a hospital I was working in, everyone put on protection to protect their eyes, nose, and mouth, except for one person. And he was a very high level physician, and he rushed in because the patient had a cardiac arrest and he exposed himself to coronavirus and he's now been lab positive. So again, we've got to slow things down and think about what is the risk when we're going in to help a patient. Some of the definitions I'm going to use is extended use, wearing the same N95 respirator for multiple encounters with patients. This is what I would prefer to use, because every time you take off and put on that N95, you don and doff it, you increase the risk. And now, again, we're seeing a lot of discussion of reusing, wearing the same N95 respirator for multiple encounters, but that increases the risk. I do not reuse an N95 from one day to the next. I may reuse it during a shift, and then I'll dispose of it. I don't use it between 2 different shifts. Our guiding principles: extended use is preferred over reuse. Reuse is by a single person. There is no sharing of personal protection equipment. We don't use, and I really have to emphasize this, that you don't use N95s after aerosol generating procedures, or they're damaged or they're moist. And then right now in our patient care, we're coming up with standard operating procedures to limit room traffic. We have a patient here in DC who's in hospital right now. I saw him yesterday. He likes ginger ale. We give him 24 cans in the morning, and that's it. No one goes in and gives him any more cans. So initially, when he first was admitted, he was ringing his buzzer and asking for more food, more cans of ginger ale. He gets his 24 cans a day, and that's his ration. Full face shields, 1 per person. Everyone needs to know how to clean and disinfect. I do reuse these. And if you aren't familiar with the EPA registered disinfectants, the hospital grade disinfectants, this is the link to this list. There's over 350 products listed. And I want to emphasize that right now, more than anything, everyone in the hospital should be reading the label of those EPA registered disinfectants. It will tell you the dwell or the wet contact time it takes to inactivate or kill the coronavirus. So again, start reading the labels. It also has these safety instructions. Eye protection, 1 per person. Again, clean and disinfect and reuse. N95 respirator. Understand that the 95 means the filtration efficiency of the respirator is at least 95% at the most penetrating particle size range of 0.3 microns. And that's being tested at a flow rate of 85 liters per minute. This stimulates the respiratory rate of a heavy workload. The N means not resistant to oil. You'll also see R95s, P95s. The R means somewhat resistant to oil. The P95 means strongly resistant to oil. Right now, we're not wearing anything below an N95 when we're giving direct patient care or having contact with patients that may have symptoms. So you can also wear an R95, a P95. There are N98s and also N100s that still suit our purpose and provide the level of protection that we need for frontline health workers. For an N95 respirator, extended use is preferred over reuse. Through your annual fit test training, you should have been taught and shown how to not touch the front of the N95 or the inside. Again, as you continue to wear that N95 respirator, you need to have eye protection for your entire shift, because we need to protect our holes, our eyes, our nose, our mouth. Fit testing. The Occupational Safety and Health Administration, OSHA, requires medical clearance for users. Fit testing for N95s. The PAPA that I wear is a loose-fitting PAPA, and it's excluded from fit testing. And we know that within hospitals, we do that training annually. I want to ensure that everyone still does that. And if you aren't familiar with wearing an N95, the hospital needs to still be having a respiratory protection program and doing the fit testing. Even though OSHA suspended the N95 annual fit testing on March 14th, that's a good faith effort. Again, that's not what we're doing in the hospitals I work in. We are still complying with the OSHA Respiratory Protection Standard 29 CFR 1910-134. We only use respirators certified by NIOSH, the National Institute for Occupational Safety and Health. All employees need to inform workers when they change their respiratory protection program, and they need to explain, and this is by following the manufacturer's instructions. If you haven't read the manufacturer insert in an N95 box, it will tell you that every time you put on or don that N95, you need to do a user seal check. This is the other card that I carry with my identification from Beth Israel. This is my N95 respirator training fit testing program. It tells me that I've passed on a 3M model. On the back of that card, it tells me how to wear it. It tells me also that I need to do a user seal check every time I put on that N95. That's both a positive pressure check and a negative pressure check. The positive pressure check is when I put my hands or clean gloves over my mask and I exhale and I see if any air leaks out the side of the mask. The negative pressure check is when I put the hands over my mask and I inhale quickly, and then I see whether there's any, the mask should slightly depress, but I shouldn't feel any air rushing in. That check is done every time you put on an N95. This is what an N95 fit testing certificate looks like. Again, all of you, if you've been fit tested, you should have one of these. You've passed. Breathe normally, breathe deeply, turn your head to the side, nod your head. And again, I go through this, all these seven, I go through at least 6 of these checklists every time I put an N95 on. I'll move my head to the side, I move around to make sure the N95 doesn't move and I don't lose the seal. Just on that user seal check, there's lots of videos out there. Ensure that people understand, they're trained, they're educated, and they've signed off, or they understand how to do that. And make sure you have a supervision system in place to ensure that people, when they do put their N95s, they are doing both that positive pressure and that negative pressure seal check. Also, part of my personal user seal check is I put mirrors in hospitals all over the place. If I'm putting personal protective equipment on and I want to know that I've put it on properly, I can ask someone through a buddy system, does this look right? But also, as part of that buddy system, we have mirrors where we check ourselves to make sure the N95's on, my eye protection, my face shield, as well as any other suits or gowns that I've put on properly. So if you don't have mirrors set up, now's the time to put them in. The current guidelines, this has been around for a number of years, issued by CDC and the World Health Organization, recommend the use of an N95 or higher, not N95 or lower. It's an N95 or higher level protection respirators against airborne transmission of bacteria and viruses. When the N95 filtering face piece respirators are not available, again, what we're seeing right now is that procedural masks or surgical masks are suggested as an alternative, but they do not provide the same level of personal protection. Becky talked about the assigned protection factor, and this comes from OSHA. This is based on manufacturers' guidelines and manufacturer information, the people that make the N95s. The assigned protection factor is an estimate of how much protection a respirator provides. Becky showed that an N95 has an assigned protection factor of 10, which means that no more than 1/10 of the contaminants which the worker is exposed will leak inside the mask. Now let's just make up a number, for example. Let's just say that we were exposed directly a million virus particles to a properly fitted, a tight sealed N95. That would reduce the exposure to 100,000. That's just a number I just made up just to illustrate what a factor of what a assigned protection factor of 10 means. On a PAPA, the loose fitting ones that you saw in the photo that I wear has a loose fitting with a cuff, has an assigned protection factor of 25. So for a million virus particles, I get exposed to about 40,000. But I've got positive pressure coming down and also air that blows that away. The PAPA loose fitting with a hood has an assigned protection factor of 1,000. So for a million virus particles, I'm only going to expose to about 1,000. So right now for our high valuable, those frontline health workers, the surgeons, the nurses, the specialists that we can't afford to take any risk with a disease that has no vaccine, no cure, we need to start considering, are we using the N95s and the PAPAs we have available, and are we allocating them effectively and properly based on risk assessments to provide the best protection we have? We're seeing so many frontline health workers actually get coronavirus and then or be exposed to coronavirus, and they're taken out of the system for up to 14 days. NIOSH also does a respirator certification test, and they perform this using an aerosol with a mass medium diameter of 0.3 microns at a flow rate of 85 liters per minute, simulating the respiratory rate of a heavy workload. That's at 0.3 microns. But let's look at the physical size of SARS coronavirus back in 2003, which is the same as COVID-19. This new coronavirus, it's 0.08 to 0.14 microns. Well, let's look at H5N1 virus, which causes avian influenza or bird flu. It's 0.08 or 0.12 micron, much less than the 0.3 micron that we use to certify the N95 respirator. Shun Lee, in his study in 2008, showed the performance offered by N95 respirators and surgical masks and did an evaluation. This paper, again, is freely available on the internet, and I'd highly recommend you download it and read it. The objective of the study was to determine the protection factor provided by N95 filtering face piece respirators versus, and compared it with surgical masks against particles representing 0.04 to 1.3 microns, the same size as coronavirus. Their results found that 29%, nearly 30% of the N95 respirators and 100% of the surgical masks had a protection factor less than 10. Remember, that's the protection factor designated by OSHA. The protection factor of an N95 respirator was found to be 8 to 12 times greater than those of surgical or procedural masks. So by count-based measurement in this study, particles of 0.08 to 0.2 microns in aerodynamic diameters are more likely to penetrate the tested N95 respirators. These are the physical sizes of SARS coronavirus and also COVID-19 coronavirus. Also tested with the respective sizes for 0.04, 0.2 microns for surgical masks. So what we're finding is that in this study, and there are other studies that support this study, the size range of these viruses fall into the most penetrating particle size range for an N95 respirator. If you're a first-time N95 respirator use, you follow your standard operating procedures as set up by the hospital. Here's an example that I use and train and teach when I'm going into hospitals. How do we store them? Again, I would prefer to see us in the shift do extended use. Once it's on, you leave it on. Every time you take it off and put it back on, you've got to use a seal check and you increase the risk. You also have to inspect that N95 if it's visibly contaminated, distorted, and if it doesn't pass the user seal check, then you can't wear it for direct patient care. We're talking about processes for reuse. All the hospitals I work in now do have standard operating procedures on how to reuse but when you take it off, how to store it, and then how to don or put it back on. Again, I'm spending all my time in a powered air purifying respirator. This is a photo taken last week in a training that I did on Martha's Vineyard Hospital for Partners Health, and also training I did for Partners Health in Boston. Again, we're teaching people for the PAPAs how to clean effectively. Patients, we put procedural masks on if it's comfortable and they can tolerate them. We also are putting, if they can't put on a procedural mask, we put on a plastic face shield. Again, there are risks, and we have to understand the risks of extended use and reuse, both contact, droplet, and airborne transmission. Reusing reduces the respirator's ability to protect, and extended use can cause additional discomfort. How do I store my N95 when I'm not using it? I use a paper bag like this one. I hang it over the handles. It allows air to circulate and dry out the mask. As Becky said, the mask gets wet from breathing, talking, and from sweat. This is what my bag looks like in a hospital. I have my face shield, my eye protection, and my N95 hanging up, ready to use. I've cleaned and disinfected my face shield and my eye protection, and I'm hanging up my mask to let it dry because it does get wet over the period that I've worn it. Again, there's a lot of optimization. We need to pay particular care to our risk assessments for aerosol generating procedures, but we do know that this coronavirus is expelled by people through talking, breathing, coughing, and we do know for studies that have been published now, this coronavirus does survive or remain active in the environment for days. It's not hours, it's days, and that depends on the surface where it lands. We were going to talk about, Becky and I were going to talk about some of the disinfection methods. We're hearing from, say, Nebraska, Duke, and other university hospitals, whether it involves UVC light, vaporized hydrogen peroxide, vaporized chlorine dioxide. And I think we should spend some more time talking a little bit more deeply and more about the risk of some of these techniques and what evidence exists to support them. But if your hospital, where you work now, is going to try to disinfect N95s, whether it be for UVC light or vaporized hydrogen peroxide, I would highly recommend you use biological or chemical indicators. The biological indicators take about 7 days to verify or validate our process, our procedures. But a chemical indicator, you'll get a real-time visual change in color to show that the concentration has been, of the disinfectant has been achieved. Again, why are we doing this? Well, we're trying to keep everyone safe. We're trying to decrease risk. And a lot of what we're doing now applies to high reliability science. There's a lot of healthcare hospitals that have been implementing high reliability science or high reliability organization principles. They've been taken from the aviation, nuclear power and amusement park industries, and now being applied in healthcare. The high reliability organization principles has five principles: preoccupation with failure, sensitivity operations, commitment to resilience, reluctance to simplify, deference to expertise. Research has shown that high reliability organizations produce sustained excellence over time. So what I do in the work that I've done in both Hong Kong, now back here in the US with hospitals, is the programs I set up focuses on provider safety, and it's all about adopting a culture of safety. The Joint Commission, you can see that their site has how to do, or their approach to high reliability in healthcare. And again, here are some of the hospitals that I'm familiar with and worked in that have high reliability organization principles. Again, in a situation like this with this virus, even though we may have a hierarchy in our hospitals, everyone is part of the team, and we have to let everyone have an opportunity to speak up and talk and express their concerns about reusing masks, but also to report when there's breaches of safety or breaches of protocol. We train, we practice. If you haven't started training and practicing wearing and donning and doffing, putting on, taking off N95s, other personal protective equipment, going through drills and exercises for procedures, now is the time to start. You do not do it for the first time when you go in to do direct patient care. And just to give you a little bit of overview and finish up on what I do in hospitals right now, when I was deployed to Hong Kong for 18 days, now back here in the US with the hospitals that I'm working with, I focus on infection prevention control policies, training of staff. We focus on process for rapidly identifying and isolating patients, like our engineering and administrative controls, patient placement, transmission-based precautions, transport and movement of patients, provider staff safety, both in the hospital and at home and when they're traveling. All the hospitals I work in right now do not wear their scrubs outside of the hospital. Every person that works in a hospital right now has outside clothes outside of their home. They have outside clothes outside of the hospital. They have inside clothes inside their home, and they have inside clothes, their scrubs in the hospitals. And those groups, those different groups that we've designated, do not mix. Emphasis on environmental cleaning and disinfection, monitoring and managing staff, moving away from 12-hour shifts to 8-hour shifts, 6-hour shifts, access and movement within the hospital, then implementing workplace controls, the engineering controls, the administrative controls, the safe work practices, and then what personal protective equipment we have available, training, education, and continual training, even though we're in the middle of an outbreak. The references that both Becky and I have talked about are available at these websites from CDC, NIOSH, OSHA, EPA list of disinfectants that you can access. Thank you, everyone. Thanks, Becky.
Are we allowed to ask questions?
I think so.
So I just had two quick questions. One was, yeah, the WHO has been insisting that this is not airborne infection, it's a droplet infection, and how that affects all the protective devices you just talked about. And also that other people have tried to sterilize N95s for reuse, but they lost their electrostatic charge, which is supposed to help entrap viruses and other particles. And is that a concern using the method you just talked about re-sterilizing the N95 masks?
Okay. I'll start with the electrostatic sprays. I have a couple of electrostatic sprays that I use personally. The electrostatic sprayer, we charge the droplets for distribution of the product, the disinfectant, to allow the chemistry of the disinfectant to work over a larger area. So by charging those droplets, they then attach more easily to surfaces, and they stick and stay there because we want to get this wet contact time or this dwell time. So if I look at bleach has a wet contact time of about 5 minutes, 0.5% bleach. If I look at, say, hydrogen peroxide, chlorine dioxide, I'm at about 3 minutes of wet contact time. So electrostatic spray is a distribution system. Even if that electrostatic spray doesn't work, we're still able to spray, and we do use foggers, we use sprayers, we use misters to actually distribute the disinfectant. The discussion we're having around whether this is airborne, droplet, contact, I think is the wrong discussion to have. What I'm doing is that in the hospitals I work in, do risk assessments throughout the day. We're finding that patients, there's such a high viral load. So we know from the work that I was doing in Hong Kong, the work that they've done in Hong Kong, the viral load in very early days of symptom onset in a COVID-19 patient, the viral load is 1,000 times higher than what we saw in SARS patients in 2003. That's in the upper respiratory tract, even before it gets to the lower respiratory tract and we start seeing signs of pneumonia. We know that this envelope virus is actually the easiest of all the germs to inactivate or kill with disinfectants, as long as we get the contact time. But we also know that coronavirus, this coronavirus, like other coronaviruses, do stay in the environment for quite a number of days. That's all been done through real-time PCR. I haven't seen any culture results yet to say whether that virus that's on a surface is still infectious, but we believe it is, and those results are coming. So again, as we talk about airborne, my focus for every doctor, every nurse, everyone in the hospital that has contact or with a patient or with anyone is how to protect their eyes, their nose, and safely, regardless of whether this is airborne or not. So that's that. We're taking this from a risk-based approach, not getting confused or getting caught up and just sort of debating, do I have airborne spread? A cough, we know what a cough does. It spreads droplets. We know talking and breathing spreads droplets. So they're the precautions we're taking at all times.
Tim, I think one of the reasons that I included the choir rehearsal example is because that's an example of a group that tried to limit contact, but they were all singing, which is known to generate an aerosol, and they had this attack rate of 3/4 of the choir. And a droplet is an example of an aerosol. It is a liquid dispersed in air, and how far it's dispersed depends on the circumstances. It's also true that if you're a healthcare provider doing an aerosol generating procedure, then you are going to be right, your breathing zone is going to be right in the area of those droplets, and that's a very high viral load. So I think Gavin's exactly right. You need to think about all the pathways are possible and protect yourself against all the pathways.
Thank you again.
Other questions?
Someone had messaged me privately. They were asking, can double masking with surgical mask add benefit?
So you're trying to create an additional barrier there, and again, we don't have evidence based. I haven't seen any documentation or data to support that provides. We would think, and we believe that putting extra layers there would provide extra protection from those droplets. So yes, but I haven't got any data to support that. But it may also, again, putting on a mask, a face shield, and eye protection not just protects the droplets and the virus from coming into the eyes, noses, but it also protects us from using our hands and touching our face. And so putting on other protection around the eyes, nose, and mouth, again, keeps us from touching our face with our hands. I'm seeing so many weird and crazy things happening right now. In Boston, they were putting coffee filters in masks, and I just said, stop it. We have no evidence. We practice evidence-based medicine in our hospitals. We have no evidence that a coffee filter inside a mask does anything. And I thought that was just, at this stage, the wrong thing to be doing. Again, we're looking at layers. Again, we'll add more protection, but again, we've got to look at this through what do we have available, what can we conserve, what can we extend our use, and again, getting down that as Becky showed in that hierarchy of controls, PPE is the least effective. And we start going below an N95, we are increasing the risk to our most highly valuable members of community, our healthcare workers. And this starts to worry me when we start to experiment like that.
So there's another principle, which is that if you increase the resistance by having more layers like this, but you don't have a seal, what happens is you suck in the air and all of a sudden you're increasing the leak. I've heard of some people doing, taping, trying to create a seal by taping. And I haven't seen studies that look at how effective that is. But I think that person is thinking about the right thing, which is to close off the seals. It just will make it harder and harder to breathe through the layers.
And the big risk, Becky, is the doffing. So you've put on you put on a procedural mask, an N95, eye protection, face shield. You've gone into the patient to work with the patient. You've been in a room, in a patient's room with a high viral load. And the biggest risk is how to doff, how to take it off. And as we start to experiment and put more layers on, we then need to rewrite our standard operating procedures to ensure that we can take those layers off safely and slowly and effectively to decrease the risk of transmission and decrease the risk of infection. And that's what I'm not seeing that done enough at hospitals that I work in.
The chat room is talking about how this is a rapidly changing situation and how both nationally policy organizations and locally programs are trying to adjust to the new information. I remember I heard Gavin speak several weeks ago and he said, oh, there's going to be a respirator shortage. And I thought, what's he talking about? There's never a respirator shortage. And yet here we are smack in the middle of that being a hot issue. So I think that this is definitely a team approach, and if you're on the ground and see things that don't seem to be jiving or fitting, I think that's exactly the conversation that this provider protection program needs to be developing.
And then we've got a question here in the chat that I'd like to, or a comment that I'd like to address, because this is so important. Every hospital has a respiratory protection program. Those respiratory protection programs need to be ramped up right now as we start to look at combinations. The N95 is a recommendation made by CDC WHO as the minimum. I prefer to wear a PAPA than an N95. As we start to see hospital administrations and other parts of the hospital say, oh, you can wear something else, it has to be based on a risk assessment. And that's, if you haven't done that risk assessment, then we need, as a collective, as a group, as a team, to start saying, let's do our risk assessment. Let's look at what we can control, what we can't. Let's look at the risk individually to ourselves before we make these rash decisions of saying, I'm going to wear, say, like a coffee filter, as I saw in a hospital in Boston. We really got to be careful because, again, the patients, now, and I can emphasize this, Becky, there's 6 COVID-19 patients in my neighborhood right now. The neighborhoods come together. We're all providing, we buy groceries, we pick up their medical prescriptions, but 3 of the 6 are physicians. And I talk to them every day and they are really sick. And I mean really sick, they're still in bed.
You had also some experience with firemen and police officers?
So here in DC, Washington, DC, we had a really bad Sunday. We had 16 deaths from COVID-19. We had 14 firemen admitted to hospital. We had 7 policemen, and we had 4 metro workers. And when we went back, and again, a lot of the work I do is with first responders. So it's, again, hospital staff, firemen, ambulance, police, and again, there's a lot of other first responders out there that are also in that group. The challenge was when I spoke to them, the firemen they had protection. It was like a hazmat suit they could have been wearing, but no one had told them to do that. And they were going into homes to pick up a patient with severe respiratory distress, breathing difficulties, to admit them to hospital, and that's where they were being exposed. Policemen are getting exposed all the time, but no one's training them on how to protect their eyes, nose, and mouth with whatever they have. The policemen I trained the other day, a group of the police here in DC, had riot masks, the riot shield masks. Yeah, they're about $1,000 each, but I told them this is how we can effectively and decrease the risk by putting a riot shield mask on. It's got a good seal because it's designed for tear gas, but it's going to work really well for this virus. And then we sat down and we actually wrote out a protocol when they had to take it off safely and then how to clean and disinfect it. So now I know the police here are using their riot shield masks as protection, and that gives me a lot more confidence in what they're doing.
Gavin, you were talking about the value of the shield in catching the droplet spatter that allows then the N95 not to be getting those droplets on the outside. What about the surgical mask, so face shield, surgical mask, N95? Have you seen that being used as a way of, again, trying to remove some of the droplets and preserve the N95?
Yes, so that's a good question, Becky. The face shields, we're having the community here are making face shields at the moment. I know communities in other counties and locations are making face shields. I wear a face shield all the time. If I don't have my PAPA on, I've got a face shield on all the time. And it's amazing when I walk up to the grocery store with a face shield on, or I go into a hospital with a face shield on, the droplets, it's clean. The droplets that are actually caught on that face shield show you that it's working, it's providing some protection. So again, face shields, for me, are pretty high on the list. I've got a question here about N95. The N95 is tested by NIOSH for effectiveness at 0.3 microns. But we know, as I showed both for influenza as well as SARS coronavirus and also COVID coronavirus, those viral particles are much, much smaller than that. And again, our certification of N95s doesn't test at those smaller numbers. So that's a really good question. It will capture the droplets. Droplets are much larger than 0.3 microns. We know that. But again, virus particles that are coming out are much, much smaller, at least 10 times smaller.
There's a question about using surgical masks and when and how and what CDC is saying and what WHO is saying. And I think that these are policies that are being looked at and revisited. And part of what's going on and what we tried to do in this grand rounds is to, again, start with the science of respiratory protection to give you the numbers, and then those all need to be translated into policy in the setting of this hierarchy of control strategies. And if there is some discomfort as you're digesting this information, I think we've perhaps given you the information, and I hope that you will be able to use it in your specific circumstance. I think one of the reasons that wearing a surgical mask, again, if you are infected, if you have asymptomatic infection, then that keeps you from transmitting your virus to somebody else. So you are protecting the world from you. And that principle is very well established for healthcare workers who are not vaccinated against influenza. So here we have, in a sense, we are all not vaccinated against COVID because we don't yet have a vaccination. And so this idea of protecting the world from you, even though you're well, is something that, again, I think programs, CDC and WHO are thinking about. Certainly a lot of people around the world are wearing various kinds of face masks. So there's a public adoption of that. I think the important thing is we don't want masks to be diverted from healthcare workers. So we don't want the public out there sucking up all the N95s, because we absolutely want healthcare workers to have that, because again, risk assessment based, they are the people who have the higher exposure.
Becky, David Chews brought up a really good point, and I reflect on the 18 days I had at the beginning of February helping the hospitals in Hong Kong. In a strong mask-wearing culture, they also did a lot of other things. So when you hopped in an elevator in Hong Kong, they used your elbow to press the buttons. Everyone did this. Throughout Hong Kong, when I walked into, as I entered and left the hotel every day, they were taking my temperature as I came in, as I came out. When I went to a restaurant, they were giving me 2 sets of cutlery or 2 sets of chopsticks, one to pick up the food, one to put the food in my mouth. So there was a lot of other actions being taken by the community, a lot of behavior change. We saw a greater awareness. And again, just by putting that procedural mask or that surgical mask on, they were less likely to put their fingers in their nose or their mouth. So that had decreased. So it's not just as David has correctly said, it's not just the strong mask wearing culture. The strong mask wearing culture, I think, leads to greater awareness of the risk of transmission, but also a lot of other different behaviors and actions that were taken by individuals.
And I think we haven't spoken about respiratory therapists explicitly. There's a cartoon that's out there that was done that showed healthcare workers taking the place of the warriors at Iwo Jima, and then a respiratory therapist running to catch up, holding on the ventilator, saying, "What about me?" I think respiratory therapists are very important in this, because the most ill people with this virus need a ventilator, and the people that know how to work the ventilators are the respiratory therapists, and they need to be absolutely in the conversation.
And Monica Joshi has also made a good comment. Again, Becky and I are emphasizing everyone should be doing personal risk assessments. In a high reliability organization, you have the ability to speak up. And again, in areas where we're working now with high viral load, if someone tells you to put something, and I was a professional witness for the 2 nurses from Texas after the Ebola incidents that they had when they caught Ebola, and when I saw the photos of what they were told to wear as personal protective equipment to go into an Ebola patient, was totally unacceptable when we ran a risk assessment, and it could have been done better. And they didn't slow it down. So again, let's start thinking about risk. Let's start thinking about the controls that Becky mentioned, the engineering, the administrative controls, as well as PPE, and how to work as a team, and how to come up with solutions to make us as safe as possible. Because a lot of hospitals are saying, do this. Everyone's doing that because we work in a hierarchical situation in hospitals, and it's making us far too unsafe, and the risk is way too high.
So I think one of the things, Gavin, is that you're accustomed to working and getting a handle on things in really high-risk situations, and the principle of these high-performing organizations is a preoccupation with failure. And maybe, I don't know if you can bring that slide up, but part of the nature of this conversation is you try to think about where can you do better? Where are the places where risk may be happening? Because this is clearly a high-risk situation, and there are many different ways to reduce risk. And so this talk is about the dimensions of the risk, and then there are a lot of folks in this organization that have done a tremendous amount of work in reducing it. And I think now our task is to look it over and say, okay, where can we do even better? What's the next step?
Yeah, you're right, Becky. In the hospital I was in on Saturday, we were looking at floor plans. So we were looking at movement throughout the hospital, not just patient movement, but also staff movement and movement of stuff and things and equipment, and looking at from a risk assessment of the floor plan as it related to space. And some of the protocols and procedures they'd put in place, where they were going to say, right, all patients were going to go to the PACU, and then some of the overflow patients would go to the OR, and we'd try to protect the integrity of the emergency department and keep COVID-19 and keep that green if we could. What we found was that some people were taking shortcuts, and that whole plan was being, the risk was just high again because they didn't follow the protocols. So we actually had to put tape on the ground, green tape, yellow tape, red tape. We put big signs. We actually had to lock and close doors. And again, we had to then work with our health and safety to look at fire procedures, but we actually had to create zones within the hospital to keep those into their green, their yellow, and their red zones, or their hot zones. And again, that takes a lot of work. And so then once we did that, we did walkthroughs. We did drills and practices with all the staff to ensure that they could work safely and effectively in providing the level of patient care that we required, but also with the other staff. Can we clean and disinfect? A hospital I was in yesterday was saying, we want a turnaround time in our rooms of 20 minutes. When I sat down with the Environmental Health Service and we did a clean and disinfection, not a clean and shine, a clean and disinfection to decrease viral load, it takes them 40 minutes. So we had to go back to the hospital executive board and say, we can't turn around safely a room under 40 minutes. That now everyone needs to know that. And so that's now been put into the standard operating procedure. So doing things like that is really making us safe, but giving us that realistic perspective of what we're dealing with when we start getting a high load of patients coming in with respiratory symptoms.
Other questions? I'm trying to look at this, go back to the chat room lists. I think so. This is talking about back to the Dr. Katzman, who's one of the infectious disease. The faculty, Michael, is asking about back to this question of the penetration and particle size.
Yes. So again, we'll go back to OSHA comes up with their protection factor based on manufacturer data. NIOSH actually tests the N95 respirators in a lab at 0.3 microns at 85 liters per minute airflow, simulating heavy workload. They don't test below 0.3. So the certification they give is at 0.3. What we do know is that the coronavirus particles are much less than that, about 10 times less than that. So again, we're providing this sense of protection, this sense of safety for our frontline hospital workers only at a 0.3 micron level. Again, that's why I wear the face shield, and that's why we constantly have things on our hands to protect us from putting our fingers and our hands on our face and our eyes, nose, and mouth.
The other thing is to point out is that these conditions of 85 liters a minute that's not a ventilatory rate that healthcare workers typically breathe at. You typically are in a room in a closed space, and so you're doing tidal breathing or maybe a somewhat increased rate. And I think that's one of the things that this particular pandemic brings to mind is whether or not there could be some real-time testing of various control strategies to see what the functional protection factor is under real world circumstance. So that's a research topic, but it obviously has practical implications.
Yeah, so Dr. Katzman, did we provide an answer for you there, or is that sufficient?
Actually, no. If you read the question the way I worded it, my understanding for a long time is that things are certified in terms of their efficiency at filtering a 0.3 micron particle because that is the most penetrating particle. Things that are smaller do not get through because of other physical chemical properties and if you read the wording there, I quoted what it says in Wikipedia. If you look up an N95 mask, and it says, although it is counterintuitive that particle sizes of less than 0.3 microns are filtered with greater efficiency, the forces which have the greatest impact on effectiveness of filtration, including aerosol impaction, interception, and diffusion, are weakest as this size for filters tested by NIOSH, unquote. So do you agree with that statement? There's a graph that shows that things smaller or bigger don't get through. That's why they test 0.3. Thank you.
No, that's a very good point, and I agree with you. Again, there has been some studies that have shown that smaller particles can have gotten through. And again, as we know, as we wear the N95 from breathing, from talking, from sweat, it gets wet. That integrity, that protection level actually decreases. And again, N95 is the minimum. It's not the maximum, and so it's the minimum level. So reusing a mask, the mask changes shape. Again, its efficiency decreases. So that's in the ideal situation that the studies that NIOSH sets up. Again, and this is from my experience of wearing lots of N95s, but also reading a lot of the literature and looking at some of the research data, the efficiency of the mask does decrease. But just come back to being comfortable. I'm really struggling right now to wear an N95 longer than 2 hours on a shift. After I've done it once, if I wear an N95 for about 2 hours, then I have to reuse it and put it back on. I can't do that for more than 45 minutes. I'm also finding a lot of people in hospitals that haven't worn N95s for an extended period of time, haven't been trained, haven't a lot of experience. They're touching and readjusting their masks. I've got video and photos of hospitals I've been in the last 3 weeks where people are touching their face more because they're now wearing an N95. And that's really important to know that's happening.
One of the things that I've seen that my patients have told me is that especially people with that are bothered by an increased airway resistance, is that the tendency is to want to, as you say, adjust the mask or pop the mask to let some cooling air come over. And it's very important to be aware if you're in an environment, you can't do that. No, you just can't do that.
Yes, Becky. And we saw it on TV the other day where the team huddled in the hospital talking in 95s and they pulled them down on their chin because they needed to have a break, they needed some fresh air, or they couldn't hear each other properly. And I went, you've just ruined the whole system. You've just increased the risk by doing that because you actually had been in with a patient. So again, we're seeing so much of that. And again, there's not enough emphasis on maintaining the respiratory protection programs you have established now. Strengthen those, focus on those, ensure that everyone still gets fit tested, but ensure that everyone gets time to practice wearing them outside of the hot zone, outside of the high viral load, outside of having direct patient care.
Michael, I think maybe if I reread your question, I think what you're saying, talking about is how is part of the rationale of using the 0.3 as the indicator is because it is the most penetrant. And so that's why they choose that to rate the respirator. But the other particle sizes are better cleared. So that's why they use that as the indicator for performance.
You know, my intent of that question was just to reassure people in general, even if studies can show that particles get through because things can always get through, that in fact there's a rationale for why scientists, physical scientists, use that 0.3, and they should not assume that smaller things always get through. Perhaps some can statistically, but it's not that things that are smaller are guaranteed to get through. In fact, things that are smaller are mostly filtered, counterintuitively. Thank you.
Yeah, I think the N95 fabric, looking and talking to the person that invented that, you know, there was a lot of thought that went into how that fabric is created and how it catches and entraps particles. So it's not perfect, but there's been a lot of technical expertise going into choosing that. Ed Langford asks about with extended use, if you have the N95 covered with droplets laden with virus. I think part of Gavin's point about you can't touch your mask is if your mask has virus on it, it could be a source of transmission. Part of the reason of using shields or some other kind of pre-filter may relate to that concern. Again, it's you knowing your situation and where you are, who you're working with, and what's the viral load, what are the transmission pathways, and where are you in that space.
And that thing that the virus will attach to the N95. It doesn't jump off. It doesn't have wings. It doesn't fly off. So once it's on a surface, it stays on the surface. It requires you to touch that surface to transmit the virus somewhere else. So again, in the training that we focus on, Becky, for N95s is you always work from the back of the head and and lean forward to take them off. You put them on with preferably clean gloves or clean hands. And then once you're going to reuse, you never touch the front or the inside of the N95 mask with your hands ever. And you never lay it down on a surface. So I was in a hospital a week ago in Boston, and they were taking the N95s off and putting them down on the table next to the nurse charge station. I went, you can't do that. And that's why we're using the paper bags again, so that we don't lay them down on surfaces.
The N95 committee that Dr. Goyle has been working on and just doing, I think, a really great job of bringing people together across the concerns. There's work on cleansing procedures and how to get things done. They're doing a lot of work and testing, and I think when there's rollout of that cleaning thing, there will be specification of how we know this is a good system. So I think again, on the ground, people are working hard to address a lot of the concerns that have been laid out in this talk.
And if we're going to clean them, Becky, as I showed in that slide, we need to have a chemical indicator or a biological indicator to start verifying, ground truthing that our system within our hospital, whether it be UVC light, vaporized hydrogen peroxide, vaporized chlorine dioxide, or any other method, actually has some effectiveness. It's not just set up the UVC lights, leave them on for over 60 minutes like the lab tests show to say that it inactivates this virus. We actually have to do our own self-validation tests and monitoring.
Okay, well, I think a number of us have to go see patients or to go to other tasks. Thank you all for being here. Thank you, Dr. Ma, for organizing this, and I am very pleased to have this medical center paying close attention to the risks that are involved, even as we're working very hard to take care of these very ill patients. Thank you all very much. Thank you, Gavin. And
thanks, everyone.